So, hello and welcome to the GHAPP MASLD Community Network meeting with Michelle Barnett. My name is Lauren and I will be your moderator, and I am joined virtually by our presenter, Michelle, and I will pass things off to Michelle to present our presentation today.
Okay, Lauren, thank you very much. I am honored to have the opportunity to present this information tonight as part of the MASLD Community Network. It's a very exciting time in the field of liver disease, and my hope is to provide key information for your practice as well as identify risk strategy recommendations for patients with metabolic-associated steatotic liver disease. I'm Michelle Barnett. I'm a physician assistant. I've been a PA for 36 years, internal medicine initially, and with GI and hepatology for the past 25 years, now with a liver disease management focus. I provide inpatient and outpatient GI care at 2 local hospitals. I'm also a sub-investigator for clinical trials related to liver disease management. Please visit GHAPP MASLD Community Network to view Madrigal MASH disease state education materials, as well as Madrigal Resmetirom promotional programs. Tonight, we will review a case study which will help outline the recommended workup and management of patients with suspected MASH and MASLD. This is case number 3. There were 2 prior cases, but tonight we will focus on Albert. Let me introduce you to him. Albert is a patient with a history of obesity, elevated liver enzymes, abnormal abdominal imaging, who has recently been diagnosed with MASLD. He is 65, Hispanic, BMI of 29. He's been referred for elevated liver enzymes and abnormal imaging. He has no alcohol history since his 20s. He has known type 2 diabetes, hypertension, and hyperlipidemia, abdominal adiposity with no stigmata of advanced liver disease on exam. Laboratory studies showed triglycerides at 89. We do clarify that he has hyperlipidemia and is currently on a statin. He has an ALT with known elevation for the past 3 years, and his hemoglobin A1 7.2. We have evaluated for other causes of chronic liver disease, and these have been negative. So if we move to, this is what we need to diagnose the metabolic dysfunction-associated steatotic liver disease, or MASLD. So with the diagnosis, we need hepatic steatosis, which we have on imaging, as well as at least 1 out of 5 of the cardiometabolic risk factors. His BMI is 29, so it's greater than 25 with the first point. His fasting glucose, we don't have, but we know his hemoglobin A1C is 7.4. We look for blood pressure readings, and that's not included in this scenario. His triglycerides need to be either 150 or on a lipid-lowering agent, and we know he is on a statin. And his HDL needs to be less than 40. His is right at 41, so he's meets the criteria. Now, keep in mind that this excludes patients with alcohol consumption into 20 to 30 grams per day. Now, 10 grams is typically 1 alcoholic beverage. So this would exclude patients who drink 2 or 3 beverages per day. Those patients would be in a different category under the steatotic liver disease. We call that MET-ALD, which is going to be a combination of metabolic risk factors as well as more ongoing alcohol consumption, but not daily use. So as we review our MASLD care pathway, this is a clinical decision-making tool that we have recently had updated to help us guide the application of non-invasive tools, or NITs, in our practice. So we look at his labs. His ALT is 43, AST 38, and his platelet count is 170. We calculate based on this his FIB-4, which is 2.22. So primary care, endocrinology, GI specialists should all screen for fatty liver disease, or now what we're calling MASLD, by identifying the patients who are at risk. If they have 2 or more metabolic risk factors, diabetes, steatosis on imaging, and then the next step would be to obtain a history, whether their alcohol use is like, look at their CBC, their liver function studies. Next would be to start with using non-invasive tests, or NITs, for fibrosis. We initially start with a FIB-4. If this is less than 1.3, then the patients are at very low risk for progression of liver disease. If the FIB-4 is between 1.3 and 2.67, those patients are identified as indeterminate risk. If the FIB-4 is greater than 2.67, then those are at high risk and have now been identified. So with our patient, his FIB-4 is 2.22, he's considered indeterminate risk. So what should you do next? So typically when we're doing NITs or non-invasive testing, we cannot use just one test to verify or to really feel comfortable with the fact that we've identified this patient and risk stratified them. So we did a FibroScan, and a FibroScan on this patient is a non-invasive test, which tells us both how much fibrosis the patient has, as well as how much steatosis. In his case, the FibroScan had a KPA of 6.7, which if we look at the step 4 liver stiffness measurement, that puts him in a low risk category. So now we've identified Albert as somebody who has MASLD. His testing and risk stratification has put him in the low risk category, with recommendations to repeat the non-invasive test in 2 to 3 years unless clinical circumstances change. And that would be with significant changes and other risk factors that would put him in a higher category. If he had been in a moderate risk, we would definitely make a recommendation to refer to hepatology for a liver biopsy or MR elastography, along with monitoring. And if he had high risk, that would be more consistent with cirrhosis, and those patients definitely need to be referred. If a patient has cirrhosis, they are going to be at high risk for developing liver cancer. They need to have screening such as an EGD to screen for esophageal varices. They're needing imaging every 6 months for the rest of their life to identify any early liver cancer that might develop. So as we review our MASLD continuum, we know that we start with steatosis, and then certain factors like obesity, being overweight, type 2 diabetes, in addition to this, leads to more progression of the liver disease. There are certain conditions that are still reversible in the early stages, from going from steatosis to steatohepatitis, and then from steatohepatitis to early fibrosis. Those are all reversible. But once you get to cirrhosis, you don't reverse that. You actually change your focus to slowing the progression of liver disease and needing to have a focus more on risk factors for hepatocellular carcinoma. So if we look at the pathogenesis of MASH and MASLD, we know that the obesity factors following the COVID pandemic did seem to increase significantly. If you think about it, people were told to stay home. They did not have access to their gyms. They did have access to alcohol, and in some cases it was delivered to their homes, and the stores were always open. And this did lead to some increase in type 2 diabetes and metabolic-associated liver disease. The big elephant in the room is that this is going to be primarily related to obesity and diabetes as risk factors for progression. So in the management of MASH, we look at the balance between nutrition, nutrients, and energy, and this is crucial. Central obesity is something that we see, which is a promoter of insulin resistance and pro-inflammatory signaling. So if we look at our clinical case again, Albert, upon dietary questioning, he explains that he eats a traditional Cuban diet consisting mostly of beans, rice, pork, corn, beef, and plantains. How can we best discuss diet with our patients, and how do we tailor dietary recommendations to the cultural preferences in food accessibility, as well as socioeconomic status? So for our patient, we look at lifestyle modifications because, again, we stratified him into the low risk category. So lifestyle modifications, dietary changes, and exercise are the mainstay of MASH treatment prior to the approval of Resmetirom last year. Resmetirom is approved for patients with F2 to 3 fibrosis. It is not used in patients with cirrhosis, and it is used in conjunction with diet and exercise. Weight loss has directly been linked to improved histologic outcomes, with 5 to 10% weight reduction being shown now to resolve steatosis and have significant anti-fibrotic effects on MASH. So lifestyle modifications are great. I think every patient that walks in the door is told most of their life, that they need to lose weight, they need to stop eating certain foods, maybe cut down on carbs and sugars, but we have to figure out a way to combine this into a program that's going to be sustainable for the rest of their lives. We know that certain things, such as the Mediterranean diet, have been very helpful versus the Western diet, which has led to more of the problems that we have now. Lifestyle measures, aerobic and resistance exercise is crucial versus the sedentary behavior that we have seen and seem to get worse during the pandemic. MASLD-friendly diet is typically going to be related to calorie restriction to achieve weight loss. Less calories in, a deficit in overall caloric intake, promotion of ketogenesis, and there are genetic predispositions of personal response to specific diets that are not clearly understood. There's an area of focus right now in research looking for genetic markers that are going to be helpful in helping us determine an individualized plan for patients in the future. We know that the Mediterranean diet, which is basically elimination of a lot of four-hooved animals, no pork, no beef, and more chicken and fish, along with higher protein. And this is supported by guidelines by AASLD, AACE, and the European guidelines, as well as primary lifestyle recommendations. So this kind of summarizes the recommendations that everybody has agreed upon. Weight loss goal of total body weight loss of anywhere from 3 to 10% is supported by all guidelines. Diet restricted in saturated fats, starch, and added sugars, basically a Mediterranean diet as a basis. Limiting ultra-processed foods and avoiding sugar-sweetened beverages. I usually start by saying the first thing you can do is cut out your sugar sodas and look at anything that's got a high fructose corn syrup and make that modification. I also sometimes challenge my patients to look at how much carbs and sugars that they have in their diet and take 3 times a day, breakfast, lunch, and dinner, and then maybe find where they could make some changes. I want them to initially be aware, because going from a typical diet to a Mediterranean diet, unless it's done with consideration for what the patient's current dietary habits are like, it's not going to be sustainable. So you really want to set them up for success long term. That might include dietary recommendations, and we'll talk about that a little bit more. Physical activity. They must participate in a structured exercise program when possible, increase activity to the extent possible, and exercise to reduce hepatic fat content. I had a patient come in who was playing pickleball 5 days a week and couldn't understand why he was not achieving any weight loss and his liver enzymes were not elevating. So you have to look at both what they're doing cardiovascular-wise, aerobic, anaerobic, resistance, and find the perfect combination. I like to give them a lot of different options, but start with the fact that they may be deconditioned and they may need to start with just easy reconditioning with chair yoga or chair exercises before they could start running a marathon or move into more aggressive treatment or aggressive exercise. Coffee, interestingly, was not addressed in the AASLD guidance documents, but it was included in EASL and ACE. Greater than 3 cups of coffee, whether it's caffeinated or not, is recommended daily and has been associated with less advanced liver disease. So we may take away certain things, but we will not take away their coffee. So if we go back to Albert, he returns for follow-up evaluation with no improvement in his labs. He admits that he has not begun any exercise regimen, but he's been trying to cut out soda. How do we work with patients to create a behavior change? This is always going to be the difficult thing to do. There's an exercise and diet adherence scale tool that is now used in some primary care practices, and this can be found online. It's voluntary. It's a questionnaire that you would start baseline and again at 6 months. And it really looks at 33 criteria to monitor daily exercise and calorie intake. If I were to use this, which I'm actually interested in printing some of these to see if I can see how it's used in my practice, I think I would let the patients know that we would start by doing this They would need to monitor this as we proceed and then bring it back into me so that we can kind of watch that. I like to look at what I can do to help them stay on track. Many times my patients will come back and say that having an accountability partner helped them. So if it's somebody that's in their family, a spouse or a child who can then engage in the exercise and the dietary changes with them, it seems to be a bit more successful long term. So as we look at the initial screening and risk stratification, I really like this graph that we'll see on the next two slides. So in a primary care office, if we confirm the diagnosis of MASLD, we've identified risk factors, including the cardiometabolic risk factors. We've ruled out other forms of liver disease, other etiologies. Alcohol is not a main factor here. Then we calculate the FIB-4. That's going to be the start of the initial screen. If the FIB-4 is less than 1.3, then they're a lower risk MASLD. If the FIB-4 is higher, then we have to then risk stratify, which is point number 2, doing either elastography to look for F2 or F3. And please keep in mind, platelets are a very important factor, as well as evidence of any portal hypertension. If those are noted, then we really have to think that this patient may have more advanced liver disease and kind of move them down into that MASH with a possible cirrhosis. Low platelets are very key to advanced liver disease and need to be further evaluated. If you've got a patient with a low platelet count, think liver disease, refer those patients. They're going to need more than just the initial stratification, because we've got to identify what's really going on. So when we assess for cirrhosis, again, we look for the platelets, we look for imaging, we look for portal hypertensive changes, which would be splenomegaly that would be noted. Another thing to keep in mind is when you're doing abdominal imaging, if you only do a right upper quadrant ultrasound, you're only going to see the liver and you're going to miss the spleen. You need to do a complete abdominal ultrasound in order to evaluate the spleen. Splenomegaly can sometimes be very subtle, but if you see it, then there's evidence of or concern for portal hypertension, and additional studies need to be done. So across the board, we've got low risk, at-risk MASH, another that's going to be F2, and the third one over is going to be at-risk MASH, likely F3, and then we've identified MASH with cirrhosis, and this is going to be in those patients with an elastography, typically with a KPA greater than 20. ELF is also used, and it's a study that I do if I have discordance with some of my other studies to help determine those patients that are at higher risk. So number 4 in this treatment model would be looking at what the treatment would be. So if a patient is at lower risk MASLD, then they can be followed by the primary care doctor, calculate a FIB-4 every 1 to 3 years, and really focus on the diet and exercise recommendations. If they're at-risk MASH, F2 or F3, there are treatment options, including Resmetirom, which was approved last year in March, for MASH, specifically with F2 and 3 fibrosis, excluded in patients with cirrhosis. We do not use Resmetirom in patients who are have more advanced liver disease. So as we conclude the lifestyle and modifications, I really just want to kind of focus on, in a primary care practice, to start with doing the FIB-4. We have Epic, and in our system, we can do a dot phrase with a dot, FIB-4, and it actually will calculate based on the patient's last labs. There are tools online that you can go to that will actually bring this up and allow you to calculate this on any patient that you have that you want to add that to. I'm trying to, with each referral I have and each patient I see, put those FIB-4 numbers there so that they are part of that decision-making process. So as we move to the last slide in conclusion, I'd like to thank you for your attention tonight as we've reviewed MASH and MASLD and lifestyle modifications. I think Albert is a typical patient that I see in my clinic, and it might be one that comes to your clinic as well. I hope that this has helped you to determine how to stratify, risk stratify this patient, and what we would need to do as far as the focus on short-term and long-term management. So with that, I will turn this over to Lauren.